Can you share a little bit about HIV and aging in the US?
Sure, it's really an emerging phenomenon. So when I started working in HIV in 2007, and when I was offered this position to do research on older adults with HIV, I was like, is this, really a thing? Um, but then I started to get into the data and see where the epidemiological trends were going. And pretty close to predictions, right now, half the people in the US with HIV are over the age of 50. In certain areas, that proportion is even greater, like San Francisco and New York. In addition to that, nearly 1 in 5 new infections are among people over the age of 50. And there's been some estimates that adults over the age of 45 are responsible for half of the HIV infections overall. So there's this idea that HIV is a young person's disease, and there's a lot of that is driven by ageism in our culture and ageism in the HIV field in general. But in most upper middle income countries or countries like Brazil, where the antiretroviral therapies have been widely available, we're seeing this aging of the population. And even if you go to low and middle income countries like those in sub-Saharan Africa, there's a growing proportion of older adults with HIV. Right now, if you look in sub-Saharan Africa, it's a little over 10% of the population, but that translates into over 3 million people, which is about 3 times the size of the entire epidemic in the United States. So this is a worldwide issue. As antiretrovirals become more affordable and more available, this is just going to continue for the foreseeable future. And so really what we're seeing, short of a cure for HIV, I think the next challenge for those of us working in the epidemic is, how do you provide care and support for an aging population who's dealing with HIV in addition to all the other challenges we face when we grow older?
Can you talk a little bit about the overlap between mental health concerns and HIV?
If you just look at gerontological research in general, one of the best predictors of depression and other mental health issues are physical health problems. So, we're already talking about a population that is characterized by a disease condition, which many have been dealing with for decades. In addition to that, you have all these other factors that can put you at risk for depression, other behavioral health issues. So, stigma is a really big one, right? Um, some of the work we've done with older adults with HIV here in New York has shown that stigma was a really strong correlate of depressive symptoms in these older adults.
Will you define stigma for us?
Sure. So stigma is basically the being labeled as being in a discredited group. It's I think it was Irving Goffman who described it as a spoiled reputation. So it's something you carry out socially. If you think of the novel The Scarlet Letter, where Hester had to wear the big A on her chest, that was a stigma. That was a very obvious stigma. Um, but for people with HIV, a lot of the stigma arises not only because they have a infectious disease, but because of certain behaviors that are associated with that, like same-sex behavior or injection drug use. So in addition to dealing with HIV, they have to deal with these discredited identities. And a lot of times that stigma is externalized into discrimination and mistreatment. This feeds into another big component of depression, which is social supports and loneliness. So when people are stigmatized, it affects their social networks in 2 ways. One, they can be ostracized by family, friends, members of their community for having HIV or having this disease. So they may be cut off. If you compound that with other intersectional stigmas like same-sex behavior or diverse gender identities or racial and ethnic minority status or ageism, this all kind of compounds. One way people react to stigma is something that my friend and colleague Charlie Emlet described as a self-protective withdrawal, in that you know that stigma's out in the world, you know that you're going to receive this discriminating treatment, so you just tend to isolate to avoid all of that. And indeed, our work has found that about a third of older people with HIV are very socially isolated and very lonely. And those are two factors right there that not only contribute to poor mental health, but to poor physical health.
Right.
So one thing we see in this population are rates of depression that are about 5 times what we see in the general population. So it's been kind of a big question in the field of HIV is, where's all this depression coming from? One thing we know is depression can also lead you to do risky things that can cause you to get HIV, to have unprotected sex or multiple sexual partners, or being in situations of sexual risk. Depression could be a immediate and long-term reaction to receiving a diagnosis of HIV. So we don't know, these, people with HIV may have been suffering depression long before they were infected. This could be an ongoing issue for them. It could be a reaction to a diagnosis. It could be a reaction to what happens to them post-diagnosis in terms of their health condition, developing comorbidities, experiencing stigma now as an HIV positive person. But one thing we know is it's way too high. I would say in general, we don't have a good understanding of the etiology of depression in this group. But what we do know is that a lot of them are not having their depression and other behavioral health problems managed in a good way. So if we get to the other side of it, alcohol and other substances can impede your antiretroviral adherence, but there's also research coming out now showing that they may make those antiretroviral therapies less effective. One study suggested that even one drink of alcohol a day could compromise the antiretroviral therapy. There are just too many barriers to care. The other thing I want to say, though, is what people with HIV themselves bring to the table. And that is incredible reserves of resilience and survivorship. So, we're talking about long-term survivors with HIV who were diagnosed in the 80s when there was no treatment available. They've been living with this disease for over 30 years. And there's something about them, which we're not exactly sure what that something is, but there's something about them that has allowed them to survive this long and to keep fighting. And that's what they're bringing. That's what they're bringing to the table. And we need to think of ways we can support that resilience. People with HIV and older people with HIV aren't looking for some kind of a handout or, some kind of like nanny care or something like that. They want to live as independently and autonomously as everybody else. What they need more is a hand up. They need some support. There are certain things we could do in the society to help support them in care. Another important source of resilience for people are their social connections and the supports they get. And so we should be thinking about what kind of interventions, programs can we do to help people enhance their social supports. I think it's important. A lot of times we talk about older people with HIV, we're talking about all the problems they face. And we do that for a reason, because if we don't do that, it's going to be really hard to get the resources we need to help people that are dealing with these problems. But we need to remember these are resilient people, these are autonomous people, these are smart people, and these are people who want and are able to control their own lives and destinies. And our job is really to support them in doing that.